How is everybody? I know, it's a long day, it's a long conference. So we're going to take a topic that, that seems a little bit mundane and make it extremely relevant to people that we all see literally every day. So first of all, I just want to thank you. Thank you for this opportunity to be here. My colleague, Dr. Paredes, knocked it out of the park yesterday afternoon with his metabolic and intermittent fasting talk. So I want to give him a shout out and say that was awesome. And so we both nerd out at work, and so this has been my I guess my nerd baby, you could call it. But we're going to talk about osteoarthritis and really the updates. There's a ton of information out there on what do you do. How many of you, just in the last week, had at least 5 people with OA walk into your doors? Everybody, right? It's super common. So we're going to talk about that, and there's been a lot of updates when it comes to do you use steroids? What about this hyaluronic acid supplementation? What about PRP? What about radiofrequency ablation? When do I use these, and what does the data actually say as far as, hey, this is going to last this amount of time or that amount of time? So let's jump into that. These are the objectives. They're pretty broad. We're going to just touch on the pathophys to review it, just to get your mind back into it. But ultimately, for points 2, 3, and 4, the whole goal of this is to give you the data, the up-to-date evidence-based information on arthritis. So whoever walks into your office and sitting in front of you, you can make the best decision you can with them. That's the whole goal of this. So what is it? It's a very multifactorial process, right? Excuse me. There's a lot of things that play into it. Your age, your gender, your body weight, your body chemistry. Have you had trauma? Have you had surgeries? Do you have any congenital anomalies? There's a lot of factors that play into arthritis and its progression over time. Really, the biggest differentiator between osteo and all the other arthritis family is that there's a lack of systemic symptoms. So we can just, as a broad sense, we're going to stick to our bones and joints. I love this slide. This came out of the Lancet in 2019. At that time, Spain was the healthiest country in the world, and this is data coming directly from Spain. And the green is going to be your osteoarthritis in the knee, the yellow is going to be in the hands, and the red is going to be in the hips. And so even in the healthiest country in the world at that time, this is extremely prevalent. It's not something that you just happenstance. It's everywhere. It's every single day in your office you're going to see somebody with it. So really, there's 3 main players. I wish I could say it's a chicken and an egg. I don't know what the third piece to that would be. If anybody has any suggestions, let me know. But really, these are the big players. When we talk about our synovium, that's the capsule, right? Everything stays inside. It's supposed to have this nice, healthy synovial fluid, keeps the joint lubricated, keeps the joint healthy. And we honestly don't know what starts this, but there's a permeability that happens in the synovium that lets in all these immune factors. Right? Your pro-inflammatory immune factors. And so they start making, big mouthful word, metalloproteinases, we'll just call them MMPs, and they just start breaking things down, right? They're not awesome. We don't like them with our cartilage. The cartilage, excuse me, wants to produce this healthy hyaluronic acid in our joint, but the MMPs really start to break that down. And over time, as you can imagine, if something is too permeable too long, the body's like, hey, something's going on here. And so then you start to get a thickening and a change in the synovium itself. Busy picture, but a lot of good information here. This is just showing healthy versus OA synovium and synovial joint. You can see there is a whole bunch of immune factors here that are going to just bring inflammation into the joint. One thing I want to just point out here, if I can do this right. There's a little button. Anyways, the subchondral area in the green on below, once those immune factors and once those inflammatory markers get in the subchondral area, that's when you're really talking about trouble. The cartilage. Normally, the cartilage, the chondrocytes, they're the ones that produce that healthy, high molecular weight hyaluronic acid, right? That's their job. And as they're exposed to these immune factors and inflammatory cytokines, they start to produce a low molecular weight hyaluronic acid. And we all know that's not the same. It's not the same at all. Those MMPs, the best analogy I can give, and I'm sure everybody in your lifetime has seen this scenario, where there's somebody who's like, hey, hold my beer. And then you have the crowd being like, yeah, do it. That's kind of what happens with the MMPs. They start to do their thing now that they're encouraged by those inflammatory cytokines, and there's nothing but trouble with the cartilage and the articular area. This is a great picture. It's from one of our cadaver labs. Actually, during my sports med fellowship, we took this picture showing a pristine, that's amazing articular cartilage on the left, and pretty significant cartilage damage on the left, on the right side of the screen. And there's definitely a radiographic classification system that we're going to get to, but just to actually see what does it even look like, that's what it looks like. That is absolute grade 4 osteoarthritis in a joint. Our subchondral friend. If you notice that orangish plate between the cartilage and that subchondral space, that's the subchondral plate, right? That's kind of that last protective layer before the damage really gets to the subchondral and that trabecular matrix. And once that happens, once you get that cyst formation, you know that there's going to be trouble. Any one of these 3 pieces can be your big nituses for pain, your pain generators. Is it one? Is it all 3? Is it a combination? I'm going to say yes, because there's no clear answer to that, especially in the literature. Now, this is a data-dense presentation, so I wanted to break it up with some fun questions. And now that the Olympics are back on, what would you want to do in the Olympics, for the Winter Olympics? You can shout it out. You can keep it in your head. Just curious to break it up. What's that?
Winter biathlon.
Biathlon, right on. That one takes a cool, calm, accurate thing. I like that. I'd choose a giant slalom myself. I love to ski. Okay, we all know the clinical presentation, right? We have like, oh, doc, it hurts to get out of my chair. The first few steps are the worst. Or I can't go up and down stairs without getting that toothache kind of pain. Or I sit for too long. They used to call it movie theater knee, right? You sit for too long, you get up, and those first 2 steps kill you. So really, there is I'll just say a status quo with activity, with volume, with duration, with intensity when it comes to osteoarthritis. I'm sure people in here are dealing with osteoarthritis, right? So the thing is, you have this normal that your body's used to, and it's okay. It'll stay at that certain level. But you go dance your pants off at a wedding, or you go walk on the beach, or you go up and down a ladder because you got to clean the gutters. Fill in the blank of anything outside that status quo, and you're going to be having an acute presentation in your office of effusion, and that crepitus gets worse, and the tenderness of that joint line is just crazy. So we all know this presentation. You don't have to have radiographs to make this diagnosis. It is very much a clinical diagnosis. The radiographs are going to be helpful in grading that. These are just some examples. Also maintain joint space. We've got the sclerotic. We've got narrowing of joint space. This is actually interesting. This is more of a varus presentation of the knee joint versus the valgus. The valgus is way more common, right? Our medial joint compartment of the knee, it doesn't matter, man, woman, ethnicity, that medial compartment breaks down before anything. We just tend to bear more weight on the medial aspect. So anyways, on this far picture on the right, you can look at that little patella. Looks like a little box turtle, doesn't it? You're going to start to see those degenerative changes at the poles of the patella, mostly superior, but you can see it on either end. And the trochlea itself is pretty angry. This is a patient of mine. Tough as nails, Texan. This woman is fantastic. She came in, she's like, Doc, my hip's starting to hurt. And I was like, well, let's check it out. So we're doing your hip exam, your fader, your Faber. She was, yeah, it just won't go. I was like, I maybe got 15 degrees and just stopped. I was like, okay, let's check this out. So it's starting to fuse itself together. So there's a reason that it just wouldn't go. Super common though. She didn't have a lot of pain. She had pain at night. But man, she did what she needed to do. I wanted to specifically show this shoulder. We call that the goat's beard as that femoral head starts to flatten and kind of go in that inferior glenohumeral space. And that talus is one of the only bones we have that is almost completely covered with cartilage, and you can see that talus has had better days. So just some radiographic examples of that. This is the classification that will be important as we look at a study later on. This Kellegren and Lawrence classification system, this is a radiographic way to determine what stage you're at with OA, right? I'm sure you've all seen it, you're all familiar with it, but there's an awesome study that we're going to talk about that uses this in just a few minutes. So this is the whole meat and potatoes of this. How do we manage our patients with arthritis? Because it's not ever going to go away. It's always going to be something that walks in your doors. This is the hard catch-22 of this, is that all the studies show that the more you move, the less pain you have. But to convince somebody whose knees ache all day to get up and move, there's a lot of inertia there. We'll just say that, right? And so that's the hard part about this. But if you do, and I'm not saying get up and run a marathon, go for a walk after lunch, after dinner. Just do easy things that keep your body moving. You feel better. So these are what we're going to go through. We're going to go through some of the main oral supplements, analgesics. We're going to talk about our steroid friends, our hyaluronic acid supplementations, PRP, stem cells. We're going to touch on that regenerative medicine. RFA, radiofrequency ablation. So we'll talk about that. I think I sent Miss Jill an updated one a little too late. I had a brain burp. And then our replacements. So really turmeric, this is one that is getting more and more popularity, but for a good reason. Turmeric, the active chemical in it is called curcumin. All right, and there are way more benefits than I think anyone thought possible of turmeric. It's going to inhibit your inflammatory cascades. It's going to work with oxidation factors. It promotes even cartilage matrix repair. So curcumin is kind of amazing when it comes to a supplement that doesn't interact with anything that we know of so far. A lot of ways that it works with our system. I'll just let you take this slide in for a minute. There's a lot of things it can do. Right? The one thing that's hard about it is its bioavailability. It is not very bioavailable unless you tag team it with pepper. Pepper increases it 1,000 times, which is incredible to me. Right? And so actually, there's some studies looking at different like nano uses, looking at the nano forms of different variants of curcumin to see what's the most beneficial. The other thing that it's going to do with is going to take at least 8 to 12 weeks for the curcumin to get to those levels where it's actually beneficial. And I'll tell you what, I've got a good handful of patients who like, sure, I'll try it. I mean, it's cheap. I can get it at Walmart. I can get it at Target, wherever. And then they stop taking it, like, ooh, yeah, maybe that was working better than I thought it was. So it definitely can be helpful. There's actually some pharmacological studies that are now, we're going to look at one in just a moment here. NSAIDs, our favorite go-tos, right? We've got our non-selective NSAIDs, we've got our selective COX inhibitors, we've got our topicals. The topicals, there's a lot of evidence that shows they're beneficial for OA. They're more beneficial than placebo. I should be very specific when I say that. So there is some benefit. But with NSAIDs, they're not just, hey, let's give them out like Pez candy. There's definitely toxicity when it comes to NSAIDs. Every NSAID out there is going to have GI and cardiovascular toxicity. They're all going to be dose and duration dependent, as you can imagine. But really, there is an increased risk of MI and heart failure with all of them, with a special increased risk of hemorrhagic stroke with our friends diclofenac and meloxicam. I love meloxicam. It's a wonderful medication for those who can take it safely. It's a once a day. It helps people if it's like, look, I just have trouble sleeping at night. Fantastic. Take it before you go to bed. Right? But there is an increased risk, and we have to acknowledge that when we give those to our patients. This is just a refresher slide for you, just to pull back that physiology of what does it do when it comes to your prostaglandins and your thromboxane. So this is just an FYI slide for everybody. Cool study, very cool study. This was by Cooper back in 2019. It's a big study, and all my references are at the end, so please, if anything is interesting to you, check out the studies because there's a lot of them in here. So on the left, they're looking at the odds ratios of heart attack with NSAIDs. On the right side, they're looking at hemorrhagic stroke with NSAIDs. Now, this is just for me as much as you, because I'm not a statistician, but the odds ratios are saying, hey, is the exposure going to affect the outcome? And your risk ratios are going to say, hey, they're suggesting an increased risk of that outcome. So they sound very similar. I'm sure in the world of statistics, there is a very clear difference. I am not the one to answer that. So if you look at this for the odds ratios, remember, if it's greater than 1, it has a higher odd of affecting the outcome. And all of the NSAIDs are greater than 1 when it comes to the risk of myocardial infarction, right? The lowest is going to be your celecoxib. Same thing with your hemorrhagic stroke. Excuse me. Your meloxicam, your indomethacin, your diclofenac, those with the risk ratios are suggesting an increased risk of that outcome in the exposure to an NSAID. So they're not benign. They're not, they're not wildly elevated like 1.9 and 1.8, but they're elevated. So the risk is still a very real thing. Tramadol. In light of the, I'll just say the opioid crisis, tramadol has been a significant go-to because it helps with pain, but we're learning more and more about tramadol. This study was amazing. Okay, they used almost 89,000 patients in this enormous systematic review and meta-analysis. So that's a huge number, right? If the initial prescription for OA is tramadol, it was associated with a significantly increased risk of mortality after over 1 year versus if you started with NSAIDs. This is the initial prescription. This isn't saying, hey, you're failing this, now we'll try it. This is the initial one. Also, tramadol may be associated with that increased all-cause mortality compared with NSAIDs. And so there's this article and this study had a ton of data in it. But when it comes down to it, is tramadol over the long term may not be an awesome option, just because it does have a risk of all-cause mortality. And also, for our friends who meet the Beers criteria, this is a dangerous one. All right, there are increased risk of falls associated with tramadol, and that's why it's on the Beers list. So are NSAIDs, by the way. Interesting. Okay, here's where the data comes in. All right, this one is looking at oral things that I've tried to get as many systematic reviews or meta-analyses I could that would be relevant to things your patients may or may not have taken. So back in 2007, there was one of the first ones I found between glucosamine and chondroitin, right? Back, I mean, gosh, they used to be like, well, we don't know if it works. It might not, but it probably won't hurt you. Go ahead, right? There was no clear, like, does it help or not? But the systematic review and meta-analysis was like, sure, it reduces knee pain in OA. Well, fantastic. That has very little side effects. Then ZOO came along in 2018, looked at it again. Now this time they added Tylenol and celecoxib. And as you can imagine, celecoxib is the most potent one, but glucosamine was actually better than Tylenol. That was kind of an interesting one. I didn't expect to see that. There was an awesome Cochrane review, 2 different articles, looking at tramadol for OA. That's what we just talked about, increase in the overall all-cause mortality. If it's the initial one, but it can also affect all-cause over time. This is a cool one by DaCosta, looking at NSAIDs versus opioids for knee and hip OA. Big meta-analysis. And so really the diclofenac, and I don't even think etoricoxib is in the US, is better than topical, which is better than opioids. In this review, this big review that they did, the opioid benefit did not outweigh the risk. And then our friend Zhang, there was a cool one, the placebo versus curcumin, and they used about 1 to 2 grams, looked at 15 different random controlled trials, and basically they're like, this is pretty efficacious, like the efficacy here is about equal. And so that was a cool one. There's actually some more pharmacological studies showing the benefits of that too. Remember, you got to add pepper. Otherwise it doesn't work so awesome. This is just showing a host of things when you look at the things that could be beneficial, right? We'll just say it that way. There's a lot of options. We're going to talk about real soon here the second one, the hyaluronic acid plus the triamcinolone, and how we can help this. Another question. Dog person, raise your hand. Yes. Cat person, raise your hand. All right. Yeah, the residents helped come up with some of these questions just to break it up. So online, I'm not sure if the debate is roaring or not, but I don't hate cats. I'm just a dog person. How about that? All right. Everybody has their favorite, right? Everybody has their favorite steroid that they jump to for whether it's soft tissue, whether it's joint injection. Everybody has their go-to, right? And so really, what are the things we can have? Over time, we do definitely, this is a known thing now, right? We can actually accelerate the progression of OA if we use them too frequently. Definitely subchondral insufficiency. Remember that subchondral plate, that's like the last line of defense before you really start losing the integrity of that joint, of the bone in that joint. We know we have rapid joint destruction. And it's neat now that there's a lot of articles in the world of radiology that are supporting, hey, we see this more and more, so if you are prescribing this, if you are doing injections, maybe you need to hold back, give it some time, or try something different. This is just a table of the ones that are out, the most commonly used ones, their concentrations, their actual duration of action. Triamcinolone actually had a lot of data in the world of horses and equine research. And that was one of the first ones. Actually, when they started looking at triamcinolone and hyaluronic acid together in the world of equine therapy, that one was kind of the nidus for, hey, this might be safe to use together, and we'll get to that. Here's our friend HA, right? Normally, remember the chondrocytes, the cartilage cells, they want to make a high molecular weight. But once OA starts setting in, it shifts to a low molecular weight. Well, all these supplements are high molecular weight, which you would expect. That's what you want to replace inside the joint. There's definitely a lot of literature on HA, and we're going to get to another chart here in a second. But there's definitely, the bottom line, the worst that you could say about HA is that it's more effective than placebo.
Dr. Hansen?
Yes, ma'am.
Can I ask a couple of quick questions?
Please do.
One question from an audience member is, do you have any recommendations on how much pepper, and is it culinary doses, or are we talking something heavier?
Oh, I like that question. That's great. So actually, there's a lot of the supplements now that are incorporating it into it. There's some liquid forms that already have the pepper into it. There's capsule forms that already have the pepper into it. There's honestly, that's not a clear answer in the data. If we're sticking to complete evidence-based, there's no strict answer to that. They just show that the pepper increases it. So if whoever asked the question, if you want to go back to the table in the slides and go to that article that's referenced, they have much clearer information on that. That's a great question. I also read a study that wasn't as supported as the pepper, but healthy fats do it. So if people like having eggs in the morning, throw some pepper on your eggs and take your turmeric. So hyaluronic acid and triamcinolone, I just wanted to show this because this is long-term treatment effects on knee pain, excluding the high-risk excluding trials at high risk of bias. So really, when Gregory looked at this, hyaluronic acid plus triamcinolone is a very symbiotic relationship that we're going to keep talking about. The WOMAC scores is a really commonly used OA tool from McMaster's and Western Ontario Universities. They created it, and they're looking at functional improvements. So let me back up one. So with this, when you think, I mean, it kind of is intuitive when you think about it. The steroid's going to calm down the inflammatory cascades, right? And the hyaluronic acid is going to try to bind to whatever cartilage it can bind to, as well as be in that joint space to help just stiffness. Really, pain and stiffness are the two overwhelming markers with osteoarthritis. So the combination of HA and steroid together is very symbiotic. PRP. Did anybody in here actually use PRP in their office? A little bit? No, that's good. I'm just trying to gauge it. So platelet-rich plasma. You draw your own blood, you spin it down, you put you back into you. So the risk of adverse events is very low. Very, very low. So you take it, you spin it, and you try to get the platelet-rich plasma. There's a lot of different kits. I put these two on here on purpose, right? One is saying, hey, it's awesome. One is saying, is it? And that's what the literature has been, which is why we're going to get to the systematic reviews and analysis of all of them, okay? Just to show you, there's so many different kits. There are so many different kits, and the kits are what make this so expensive. I'll tell you what, being at an academic institution, we charge, I think, $450 for a PRP injection. I know there's a lot of people in private practice who are like upwards of $1,500, $2,000. And so the kits are expensive. I think we charge for the kit and for the injection cost because we're a teaching institution, right? And so you're going to see it across the spectrum of a lot of different ways and how people go about charging for this. Excuse me. Here we go. There's a lot on PRP. A lot of actually really interesting literature, finally. They've been looking at this for the past 10 years, and I'm very surprised the FDA hasn't approved it yet, because there's nothing but really good. Number one, there's no harm in PRP, in injecting it into a joint. The most looked at joint is knee, because it's the most common, but so far there is zero literature that has shown any harm in putting PRP back into a joint. So let's start there. At the top, DiMartino. They looked at PRP versus hyaluronic acid, 5-year follow-up, double-blind, random control. They both improved functional status at 9 and 12 months. Not bad, right? Then Tang came along. He's like, hey, we're going to look at this again, PRP and hyaluronic acid, this time meta-analysis. They found that PRP was better for pain and function at 3 and 6 months. He et al. Now we're looking at HA versus steroids for knee OA. So for 1 month, in the short term, steroids win. Steroids are going to calm it down in that short term, pretty great. Long term, anything greater than 3 months, that hyaluronic acid is going to win. All right? And then we got Arias Vasquez, Prolo versus HA, again, for an EOA. This time we're looking at systematic review of all the clinical trials. Prolo is about equal to HA. Pretty cool. For those of you who are not familiar with Prolo, short for proliferative therapy. It's where you're using a dextrose solution and injecting it into a joint. So you're basically firing up that immune system. You're causing an inflammatory response to draw those growth factors to heal things up. That's a nutshell of Prolo. Prolo is cheap. I mean, a little bottle of dextrose is what, like $5? Like, it's cheap to do this. And so the fact that Prolo was equal to HA, I was surprised by that. I didn't expect that to be what it is. And then they found that, excuse me, PRP is superior to Prolo. That was a big systematic review. Belk, another one, PRP versus HA. Again, up to 12 months this time, PRP seemed to be the winner. Tavasoli, single, this was actually a cool one. We're going to talk about this a little more. They looked at a single shot of PRP versus 2 shots of PRP. Like, is one better than the other? And they found yes. You're going to have increased, improved efficacy of the PRP with more than 1 injection. That's not a week apart. That's like a couple of months apart. Okay, just to keep the proliferation going. We're going to talk about that. This is going to come up again. And then Smith, we're looking at hyaluronic acid versus steroid and hyaluronic acid. Remember that symbiotic relationship I was just talking about? So that symbiotic relationship actually had reductions in pain at 2, 4, 24, 36, and 52 weeks. So that was a great combination. It's a very symbiotic combination, and it's worked really well. This is probably my favorite slide of this entire presentation when it comes to PRP, because you have to acknowledge the non-responders. Ethically, you have to acknowledge the non-responders. It has to be part of your consent, essentially. All right? And this is intuitive. And so the CIATI, the study I was just talking about, they included all grades of osteoarthritis, all of them. And as you can see, if you're at like grade 1 to grade 2, you do pretty darn great. That KL is that Kelligan-Lawrence radiographic score for the grade of OA. All right, so if you just had grade 1 to grade 2, holy smacks, up to 75% of people responded. I'd go with that therapy every day if I knew that was the result, right? That's awesome. As you start to get to grade 3, maybe 2/3, you had a solid 66%. You get to grade 4 OA, you're at a 50-50. Ethically, I can't tell you this is going to be amazing if I have data that shows that it's a 50-50. And intuitively, it makes sense, right? The more broken down the joint is, do you think PRP is going to reverse it? That's not what the data shows. It's just going to help with your stiffness and your pain and your functional scores. So this is an awesome slide to say, hey, what do I have in front of me in my office? Have we taken x-rays in the last 3 years? Like, what's going on in this joint? If I see degenerative changes everywhere and you're literally bone on bone, is it ethically okay for me to say, you know what, let's give PRP a try. I think it would really do awesome for you. And I'm just throwing that out there. I'm not saying yes or no. I'm just throwing that question out because you have to acknowledge it with the non-responders. Okay, this was one from the residents. Dictation or scribe, what would you choose? Who's here for dictation? Ooh, how about a scribe? Oh, everyone else just do it yourself? I like it. That's right. All right, so now we're going to get into the world of stem cells and exosomes. I realize this is a busy slide. I'm not going to read this slide to you. Did you have a question, sweetie? PRF? That's okay. All right. Sounds good. So when it comes to the world of stem cells, just as a backtrack physiology reminder, cell biology actually reminder, every single cell, prokaryotic, eukaryotic, makes exosomes, right? Something happens to the cell. It gets squished, it gets pushed, it needs to fix the membrane, whatever the case may be. That signal gets sent to the nucleus, right? So there's going to be a genetic response in that DNA of the cell to produce whatever protein, whatever chemical, whatever is needed for that signal, right? It's going to ship it to the endosomes, they package it up, and there's your exosome, right? That's where they come from. In the world of stem cells, it's a cell. So stem cells produce exosomes. The thing with the mesenchymal stem cell is we can't make it be what we want it to be. That's the hard part. It's coming from a signal inside that cell for a nerve cell, for a spleen, for a skin cell, for a cartilage cell, right? So when it comes to stem cells, yes, they have enormous potential. They do, just by default of how they respond to a cellular signal. It's what they kick out. They're going to contain anything from genetic information, protein information, lipids, whatever it is that was signaled to that nucleus, they're going to package up and send out as an exosome to fix whatever problem that they have. It can be physiologic or pathologic. It can go either way, right? So stem cells have this enormous potential because of what their DNA is going to say what we need, right? This is how it is collected. There's usually 3 typical ways. There's bone marrow, there's umbilical cord, there's adipose tissue. Adipose tissue is probably the most common and cost affordable for people, but this is still not a cheap thing whatsoever. So really, they first of all, you have to isolate them. You have to find the stem cells, you isolate them. Then you modify them. This is the part that is the, I'll say gray area, for lack of a better term. So when we try to encourage a stem cell, we currently don't have any means to determine exactly, hey, if I put these things in this petri dish, I'm going to stimulate the stem cell to be a muscle, a nerve, a toe, a skin, like whatever that is. We don't know how to do that yet. There's a ton of research going on because of the enormous potential for people with all sorts of maladies, right? So there is a huge potential here, and this is how they try to spin it down. So we're going to try to modify it. We're going to try to treat the mesenchymal stem cells with something to get these exosomes released. And then we're going to try to isolate those, and now we're going to put it into your joint. There's a lot of steps there, right? And the cool thing about this is the potential. The hard thing about this is we can't steer the potential just yet. Maybe in like a broad sense, we're trying to get it to go, but there's no one thing that we have to direct them. So in the world of anecdotal evidence, there's a lot. I'm sure you guys all know people who are like, hey, you know what, I had the stem cell injection. I feel like I'm 25 again. This is great. Some people are like, I just spent $4,000 and I feel the same. Because we can't, there's no one way that we have to drive them to what we want to be yet. We don't have it yet. We might in the next 10 years. That would be amazing. But currently right now we don't. We just don't. So here are the studies that I found on stem cells. All right, when it comes to actually like randomized or prospective or systematic reviews. All the abbreviations are below. So it was kind of cool, the first one, ZOW. So they looked at leukocyte-poor PRP versus adipose stem cells versus bone-derived stem cells versus, I'm just going to put saline in your knee. Right? So there's a lot of pieces in this study, in this first one. They found that the leukocyte-poor PRP was the most effective for functional improvement. The adipose stem cell improved pain for about 12 months. And both the leukocyte-poor and adipocyte stem cells were better than placebo. This study, if you want to read it, has a ton in it. All right, there's a lot of things in this study. It's a good one. It'll give you a lot of information. The next one, Garza, looked at just mesenchymal stem cells in treatment of knee OA, so double-blind prospective. And what they found was dose-dependent high to low. The stromal vascular fraction, I'm like, oh my gosh. Basically, it's what are we getting out of the stem cells? That's what they call the stromal vascular fraction. Again, there's the WOMAC, the OA scores. They improved about 12 months. Bastos, we're looking at, hey, okay, if I do a combination of stem cells and PRP versus stem cells and steroid, then what happens? Well, the mesenchymal stem cells with or without PRP improve function and pain 12 months compared to the steroid. That's pretty cool. Lee looked at intra-articular adipocyte mesenchymal, and it was just versus control. And so about 6 months, they showed improvement compared to the control group. So there's definitely some literature that's starting to be out there that stem cells are helpful, right? There's no harm. That was another one that so far in all those studies, stem cells have no harm. There's no harm in putting stem cells back into your own body. Oh, this one. This was another fun one with the residents. If you were a wrestler, what would be, or you could say if you were a baseball player, a softball player, and like you were walking up to the plate or you were about to enter the ring, what would your walk-up song be? I know, this is a fun one. Mine would be Joker and the Thief by Wolfmother. I don't know if you know it or not, just the first 30 seconds. Other than that, it's a weird song. So anyway, so I wanted to pause here because, like I said, this was, I gave Miss Jill the most updated version, so hopefully we can get it out to everybody, because there's one thing that was not in here that I just had a brain burp on, is radiofrequency ablation. So this is in between that injection and replacement. That's why we're stopping here, right? So radiofrequency ablation, the studies on that, there's about 3 or 4 meta-analysis, systematic reviews, single-controlled randomized trials that I looked at. And so really the outcomes are similar. So in the world of interventions, right, the hyaluronic acid, the PRP, the mesenchymal stem cells, and RFA, they're going to give benefit up to about 12 months. There was one study that tried to look at the long-term outcome of RFA, and it was still about 12 months. So if you just stop and look at all of these, all the data and all the information, whether it's PRP, whether it's Prolo, whether it's hyaluronic acid, radiofrequency ablation, they're all looking at about a year, which is really super interesting when you think about it. There's nothing that says, hey, this is past a year, or this is longer than that. There was one study that had that 5-year follow-up that did pretty well. But this is the hard part. This is like who's sitting in front of me. I've got a darling 93-year-old who has bilateral OA in her hip, and she wants injections every 2 months, and I don't want it to make a steep and slippery slope to her not being able to move anymore, because we know steroids degenerate the joint, right? So is RFA the next best thing? It might be. That might be our next conversation, because she wants to move. She wants to do things still, right? So there's always this cost benefit. What's the ratio to it? Instead of just saying, yep, replace it. Some people don't want to replace it. There's some awesome stories. Hey, I'm back, walking my kid, or golfing, or doing gardening, things I like to do within 3 to 6 months of replacement. There are some people that we've seen, everybody has seen, this knee was amazing. I can't even straighten this one. It's been 9 months. And that's the hardest thing, is to predict who's going to do awesome and who isn't. And my orthopedic friends, they're great at what they do, but nobody has a crystal ball to say, hey, you're going to do amazing for both knees. Let's do them. They don't have that yet. And so it's hard. It's hard to say, how can we keep you going as long as we can before we have to jump to that replacement? Because really, truly, we all know replacement is solely a pain-relieving procedure. It's not going to give you a function to go run a marathon. I suppose you could, but you break down the hardware faster, and instead of 20, 25 years, you might get 10 to 15, however you beat it up. You know what I mean? And so it's one of those things where I want to give you all the data to make the best decision that with you and your patient, that shared decision between the both of you to what can be the best for you, right? And we all know about replacement. I wanted to throw OMT in there because obviously it's one of my specialties. We do it every day. When it comes to OMT, there weren't any random controlled trials, and this was 100% evidence-based. And I would love to add this as evidence-based. We just don't have the data on it yet. What we do know, we do know that with any arthrogenic inhibition, right? My knee hurts, the brain's going to shut down how the quads and hemis work together. So we know that the glute medius and the soleus take over 10 to 15 times their job. That's in kinematic research. We know that. We know these patterns of compensation. Right, so OMT is a great adjunct to that. There's just no hard data on how long does it last. Are they going to get relief for like 3 weeks, 6 weeks, 2 months, whatever that is. Because anytime your brain registers pain and shuts it down, there's going to be a pattern that compensates. There just is. It doesn't matter what joint we're talking about. And every joint has its own predictable pattern of how it compensates. And that's where OMT can be a really cool tag team. Maybe it's a once every 3-4 weeks you come in like, you know what, my hip's super tight. I know it's from my knee. Can we get it straightened out? Sure, of course we can, right? They're all useful modalities. Anytime you can get the brain involved, I'm a fan of using the brain every single time. So whether it's an activation, whether you're using percussion, whether you're using muscle energy, anything where the brain has to be involved in activating something, I'm going to do it every time. So this is another one. It's not hurtful. Nobody's going to do HVLA on a grade 3 to 4 osteoarthritis. That's silly, right? It just is. There's a lot of other ways. Because your body is stiff for a reason, right? It's guarding it. There's a reason you have the stiffness. It's your body's way of shutting you down so you can't keep hurting yourself, right? So that's where the stiffness comes from. So really, you're not going to force anything, but hey, how do we balance the load? If we know that you have OA in your hips and we know that your hip flexors are tight as ropes, let's share the load across the rest of your back and quads and bum and see if that helps you with your pain more so than just keep giving you meloxicam every day. You know what I'm saying? So this is one of those interventions it's easy and it's tolerable and people do really well with. So this is just a summary, right? Just in general. Corticosteroids alone, you're going to get about 1 to 3 months. That's about, some people do amazing. Once you knock the pain down and they get back to their status quo, you won't see them for 2 years because they do awesome, right? We've all had those people too. And all they needed was just to get the inflammation down and then they go, right? But in general, with the studies, when we're talking about more progressive OA, you might get a solid month, maybe 3 would be great. The tag team of hyaluronic acid and steroids, very beneficial, very symbiotic, right? And we saw that in one of those meta-analyses. Hyaluronic acid and the PRP is beneficial. There seems to be a little bit of synergistic effects here as well. Not bad. We know that the PRP with at least more than one does better than just with one. Good functional outcomes. Stem cells, you're starting to have data, but some of the random controlled trials are still lacking. So, you know, I don't have a crystal ball. I would love to say, hey, FDA is going to approve PRP in the next 6 months. That'd be great because it's pretty beneficial for a lot of people. But in light of all these, even if we interject radiofrequency ablation in here also, is that they all are giving you improvements in pain and function for about 12 months, right? So you're kind of like, oh, well, which one do we go with? Because there's no one that says, oh yeah, this actually is going to give you 2 years or 3 years, right? Miss Jill, yes ma'am.
Couple of questions with regards to stem cells. First of all, are they FDA approved?
No, not yet.
Okay, and then the next question is, are there any studies on umbilical stem cells?
Not in the state of Texas. That is a giant no in the state of Texas. They're actually, what is it called? Charlie's bill? Was it 2017 was passed? Charlie's Law, Charlie's Bill. Do you guys know what I'm talking about? It said, yes, that basically it was bypassing the approval system to be able to do research with stem cells. But they were specifically talking about adipose-derived and bone-derived, not umbilical-derived. That in the state of Texas, that is a giant absolutely not. But I actually don't know. I'd have to look up some of those studies. I think they're out there, but they weren't included in the systematic reviews and meta-analyses that I found. Yes. Yes, ma'am, I'm ready. Yes, sir, please.
Dr. Neil Reardon, good resource to look at that. He's got a place in South Lake that does great research in Panama.
Cool.
Be the point which you're saying you can't get it done. He does mainly umbilical cord work.
Awesome, thank you.
Preeminent international search on stem cells. Neil Reardon.
Neil Reardon. We'll check him out. Thank you.
Yep.
Yes, ma'am.
So I can speak to that too. There's a company, MyMedics. They're pretty big in wound healing, and they use placenta umbilical cord stem cells as well. They recently, as of this year, pulled back the product that they were using to inject into the joints because of a billing. But up until a year ago, you could. And actually, the VA was offering, and my husband had it injected into his shoulder after he had a tear, and he's had a really good recovery after that. And so they may come back, and they were, I mean, we were using it in Texas, but I know that there was an issue because of Medicare reimbursement billing, how and so forth. But what I was referencing back to earlier was PRF, which is the platelet-rich fibrin. So there's
yes.
new data that's coming up that's saying it's essentially the same thing, except you're spinning it slower. And so because you're spinning it slower, you're getting more of the red blood cells there. And so the data that's coming out is saying that PRF is superior to PRP, but I don't know if there's actually data that went head-to-head specifically for OA. And then the other one that I had a question about was peptides. That's another one that's coming up, and they're talking about it being very beneficial where you inject it near the joint and people are apparently responding, but I haven't seen the studies.
No, that's super awesome. So thank you for that. That's super great to know. A friend of mine has a private practice also in the area, and the regulations that he ran into when it came to umbilical stem cells was a hard, fast no, because it wasn't for something like wound healing. It was, I think it was for a shoulder or a knee or something. Anyways, in the world of wound healing, whether it's burn units, whether it's just wound care centers, it's that's where PRP started. PRP got its start in burn centers. That's where they found the initial efficacy of it. They're like, wow, there's a reason that plasma on your skin heals so well. And so that got transferred to dermatology, like, hey, well, if it works obviously with skin, we can use it with skin. And then it shifted its way into the world of musculoskeletal things, and that's where we are today with trying to see how well it works. So the fibrin, yes, there's a reason. So thank you for saying that. When you spin down PRP, there's a certain speed you're supposed to spin it at, right? Each of the kits is going to tell you exactly what. But if you do slow it down, remember it's going to separate it by density, right? And so if you slow it down a little bit, you're still getting some of that whole blood in there. And actually, some of the very first studies that came out looked at whole blood with lateral epicondylitis, and that it was efficacious. It hurt like a son of a gun because you're putting whole blood back in there, and that ticks everything off. But they showed improvement with that. That was one of the first studies that came out when they started looking at this. And so it makes sense that I would love to look for studies with the fibrin. It makes sense. You add some of that whole blood in there with it. It's not necessarily leukocyte poor, because that's been a big debate. Leukocyte poor, leukocyte rich, which one does better? But when you get that fibrin in there of that whole blood, it makes sense of firing up the inflammatory system to bring even more growth factors to heal it, from a physiology standpoint. So that's cool. Thank you for that. That's great.
Couple more.
Yes, ma'am.
Sorry.
Sure.
Regarding the treatments, with your recommendations, are they only pertaining to the knee, or do they also include a hip joint?
Great question. I love that. So the vast majority of the data is on the knee. There are some studies on the hip as well. One of the hip studies were in here, but it covers all joints, right? It covers all joints because joints have generally the same articular cartilage. They've got the same synovial fluid. They have the same overall response.
And then the last question I have for now is, what effect does shoes versus orthotic shoes have on the knee for OA?
Oh, I love that question too. Just biomechanically minded, right? And this comes, I'm going to nerd out for a second, so just hold on, stick with me. Right? If your foundation of your feet is flat, you've got that pes planus, you're automatically changing the dynamic of your foot, ankle, and lower leg. Do you guys know what a mitered hinge is? Remember those cartoons where you get a cog that goes this way and then the other one that drives with it? They drive each other? That's what a mitered hinge is. Your foot and ankle and your lower extremity, your shin bone essentially, that acts as a mitered hinge. Right? So if you have pes planus, that automatically internally rotates your tibia, which now has an effect at your knee by default. It's the opposite end of the same bone, right? So now if you have an internal rotation of your tibia, now it depends on what is the hip doing to meet that there, right? So if there can be a way from the bottom structurally just to give some stability to that, I don't know why it couldn't help OA. I can't give you any specific studies that say that, but functionally and biomechanically, I don't know how it couldn't at least help. It certainly wouldn't hurt somebody to even out that structure. I mean, if you're 85 and you've been flat-footed your whole life, that might be a little mean to put you into orthotics. You have to do that real gradually. But really, truly, if that's how the mechanics work from your foot and ankle to your knee, there has to be some benefit into stabilizing that. Great question. Anyone else? Let's see what else we got. We know about replacements, right? We know about unicompartmental, total, we know about all of those. Really, with the improvements in technology, they're pushing 20, 25 years. That's just with activities of daily living, right? That's not saying, hey, I really, it's been my entire life bucket list. I want to hike in Patagonia. I just want to do it once. But the training, you know what I'm saying? Like, there's ADLs that's going to last 25 years, and then there's I have something I want to do, and the more you do, it's going to shorten that lifespan as a general rule. Yes, this is it. It's a cliche, but it's really true. Any questions? Yes, ma'am.
Got another one. Can you do PRP without industry kit, just the centrifuge and tubes?
You can. That's how they started it. You can. The kits help separate it better, but some of the easiest was just a tube, and you spin it, and you have to be very gentle with your needle as you pull out that middle layer. That's all. So sure you can.
How about now?
There we go.
Okay. What are your thoughts on peptides?
I have to read more about it.
Okay.
I don't want to say anything stupid. I want to at least have a baseline knowledge of how they work before I comment. So it's a great question. I'll probably go read about it this week. It sounds really cool. Any other questions? Well, thank you guys. Thank you for letting me be here today. A lot of references.